So I'm actually not going to talk about Graves' disease, so thank you for talking about Graves' disease, and I'm actually going to talk about thyroid autoimmunity and hypothyroidism, because the management of a woman with Graves' disease during pregnancy is really quite challenging and takes a lot of time and really takes almost about 30 minutes to discuss, and I believe Dr. Cooper may be discussing this in one of his cases. So what I will talk about is first gravid thyroid physiology and some newer insights we have about reference ranges. I will then talk about thyroid autoimmunity, something that's very common, as about 15% of women in reproductive years have positive thyroid antibodies, maternal subclinical hypothyroidism, overt hypothyroidism, and I'll use as a background the ATA 2017 guidelines on the management of thyroid disease, which you can download from the ATA website. So when we talk about what happens during pregnancy to physiology, one of the first things that happens is you have increased renal iodide clearance. So depending upon dietary iodine intake, which fortunately in this part of the world now is really quite good due to salt ionization programs, that can lead to goiter in areas of the world where the iodine health is not quite as good. So how much iodine do you need when you're pregnant? So if you look at the World Health Organization or UNICEF and you focus on pregnant women, it's about 250 micrograms per day, whereas in the non-pregnant adult and in older children over the age of 12, it's about 150 micrograms. So generally we get iodine through food that's grown in soil that has iodine as a trace element, or by eating fish from the sea. But since that is not universally available, what most countries have done is gone ahead and done salt ionization programs. And this is the most recent global scorecard on iodine nutrition in 2017. And if we look at the area of the world where the South Asian Federation of Endocrine Societies is, you can see that actually gray means pretty good. The only reason India is subhatched is because there is subnational data. I've actually spoken in India, and it depends upon which state in India you're actually in. There's differences in salt ionization. But Sri Lanka, as many of you know, began salt ionization in 1995 at 45 parts per million, and then actually decreased it to 25 parts per million in 2005. So if you then try to do surveys that look at the percentage of households that are currently using iodized salt, you can see in Southeast Asia it's actually pretty good, and in Sri Lanka it's 68%. You know, ideally the global iodine network would like it to be over 90%, but over 60% is considered quite good. Now, the other things that happen during pregnancy are with the binding protein changes. As you know, thyroid binding globulin is the main binding protein, and that goes up as estrogen levels increase, and there's decreased clearance of the protein. And for the endocrinologists who might want to know why, it has to do with changes in glycosylation of the protein causing decreased hepatic clearance. There's also changes in albumin as the volume of distribution gets larger. And so what happens is thyroid hormone levels go up, and the free T4 assay doesn't perform very well. So if we actually look at this, and I did ask Noel before I came whether I should be using micrograms or picomoles, and he suggested micrograms, so I've shown you here in micrograms the total T4 in the normal non-pregnant range shown in green, and then the total T4 during pregnancy in the first, second, and third trimester. So you can see it goes up, but I think what's important to see is that it goes up early, and it stays pretty much the same. So that overall, the normal range in pregnancy for the total T4 is about 1.5 times the non-pregnant reference range. The free T4 is a little bit more problematic. So shown here are just two automated assays, one by Alexis and one by Toso, with the normal ranges shown in green, and then the free T4 shown by trimester in normal women. And what you can see is that the free T4 decreases through gestation, but importantly, how it decreases is variable. So for example, if you look at the Toso assay on the right, and you look at the lower limit of the non-pregnancy reference range, you can see in the third trimester, almost 80% of people might be labeled as abnormal. So it's really important to know how the free T4 assay performs during pregnancy. So the next thing that happens that complicates our diagnosis of pregnancy and thyroid disease is that we know the TSH changes normally. And as you know, in the first trimester, HCG increases, and HCG and TSH share an alpha subunit. And what happens is that the HCG can bind to the TSH receptor at the time that it peaks. So here at around 10 weeks, you can see the peak in the HCG here, which is mirrored by the decrement in TSH, and this is because of the structural homology between the two proteins, so that HCG can bind to the TSH receptor and has thyrotropic activity, as indicated by increases in free T4 when you look across a population, and you correlate as HCG levels go up on the x-axis, you can see the free T4 goes up, so that the TSH will go down in the first trimester and then will come up again as HCG levels go down, and hence its thyrotropic activity goes away. Lastly, the placenta has one of those enzymes called a deiodinase, specifically the type 3 deiodinase, that inactivates T4. So overall, the total body T4 pool must increase by about 40 to 50% to maintain a euthyroid state. So if your thyroid can't do that, then you're not going to be able to maintain that euthyroid state in pregnancy. So what is a normal TSH? Well, before 2016, most of the guidelines, including, I'm aware, the Indian Thyroid Society has published guidelines, have recommended that the first trimester TSH should be below 2.5 and the second trimester below 3, although it's ideal that you compute your own trimester-specific values. However, since then, there have been a number of studies, and I just want to show you that this is worldwide. There have been here 14 studies that have evaluated normative TSH ranges in women who are antithyroid antibody negative. Generally, women, some of them are in borderline iodine deficient areas, but a number of them are not. And some variation can also be via ethnicity, but a normal TSH at the end of the first trimester can be over 3. And so this is what led to the ATA 2016 guidelines revising those criteria of 2.5 in the first trimester and 3, but still saying that we're obviously possible. Try to develop your own population-specific ranges, which is generally not always practical. So given that you can't, one of the things you can do is at the end of the first trimester, when HCG is peaking with the thyrotropic activity, reduce the upper limit of normal in the non-pregnant reference range by 0.5. So maybe the upper range of normal is around 4. And the lower limit of normal might go down as well a little bit, so it might be around 0.1. But remember, as HCG goes away after around 15 weeks gestation, the TSH will come up, and you probably can use a non-pregnant reference range. So not quite as stringent as before the 2016 guidelines. Okay, so let's now turn to thyroid autoimmunity. So lots of women in reproductive ages have positive antibodies present. And when you begin to think about ways that thyroid autoimmunity in the presence of even euthyroidism could be associated with adverse pregnancy outcomes, there's potentially two. So thyroid autoimmunity, it could be that there's some destruction of the thyroid with decreased thyroid hormone reserve, so that you're euthyroid when you're not pregnant, but since there's a 40 to 50% increase in T4 pool when you're pregnant, can't quite make enough thyroid hormone. But it also turns out that antithyroid antibodies, independent of, for example, anticardiolipin antibodies, may also have effect on some of the decidual autoimmunity and cytotoxic T cells, so that potentially there could also be increased miscarriage due to some of these autoimmune changes. So if we were to posit that perhaps thyroid antibodies are a marker of the fact that that thyroid doesn't have 100% reserve available, maybe it would be that women who are antibody positive can't mount that increase in free T4 that we saw that occurs as HCG peaks. And so this is what Robin Peters has done with the Generation R study in the Netherlands. So you can see in the TPO antibody negative women, the free T4 goes up as HCG goes up. But look on the right side over here. In the TPO antibody positive women, where there may be some decrement in reserve, it doesn't change, it remains flat. And then similarly, if your free T4 isn't going to go up, you're probably not going to have that decrement in TSH, and your TSH won't go down. So shown here on the left is the normal decrement in TSH that we just looked at that happens when HCG peaks in antibody-negative women. But in antibody-positive women, the TSH doesn't change. So it may truly be a marker for the fact that the thyroid just can't get that increased production of T4 that's required during pregnancy. So what are the possible associations? So remember, association is not causality. If you're doing epidemiology, you look at a potential exposure, which would here be thyroid autoimmunity, variably defined as either TPO antibody positivity or thyroglobulin antibody positivity. So the studies are not very clean. But you would say, given that this woman has the exposure where you can measure antibodies to the thyroid, and you compare those women who don't have it, what are the types of adverse consequences that you can see during pregnancy? What is the association? Not causality, but association. So you see higher miscarriage risk, and you see it in all three of these populations of women. Unselected pregnancies, 7 studies have shown it. Subfertility, 9 studies have shown it in women undergoing assisted reproductive technology. And in women with recurrent miscarriages, 7 studies have shown the association of higher risk if you're antibody positive. In addition, there are about 6 studies that have looked at higher preterm delivery risk. But this is not causality. It just means that it's more likely to be observed. So let's now turn to a patient that you might all see next week. She's 9 weeks pregnant. It's her first pregnancy. Her mom has hypothyroidism. She is antibody positive. Her thyroid exam is normal. These are the antibodies that were measured. Her TSH is 3.4. And she wants to know what to do. So how many of you have seen patients like this? How many of you have treated them with thyroid hormone? How many of you have not treated them with thyroid hormone? You can raise your hand both times, David. Okay, so let's talk about this. This all started because 13 years ago in Italy, there were 2 studies consecutively published by Roberto Negro that used a randomized controlled trial. So in science, that is the way that we then try to establish causality. We take women with the exposure, positive antibodies, and we randomize them to either get thyroid hormone or not, and we look for the outcome, miscarriage rate, preterm delivery rate, and we compare them to control women. And it was found that, yes, if you treated these women who had TSHs in the normal range but less than 4.2 with positive antibodies with thyroid hormone, they actually had decreased miscarriage rates and decreased preterm delivery rates compared to untreated women, and the same as controls. And that in medicine is how we take an association. We try to say, aha, maybe we can do something about it. But 2 very small studies, one of 110 women and one of less than 100 women, in the same population in southern Italy. And the TSH was up to 4.2. And then it literally was 10 years later. Look, 2016, 2017, and 2017, 3 more studies, one from Roberto Negro in Italy, one from China, and one from Iran, looking again in a randomized controlled fashion if levothyroxine could really decrease miscarriage and preterm delivery rates. And this time, Roberto Negro only treated women with TSHs of less than 2.5 rather than less than 4.2, and started it early in pregnancy. In China, they treated women with a normative TSH defined as less than 4.78 prior to IVF. So these women actually got thyroid hormone prior to getting pregnancy. And here in Iran, they treated women with TSHs of less than 4 in early pregnancy. And there were absolutely no effect on miscarriage or preterm delivery. And this is what we had when we wrote the ATA guidelines, where we said, you have an early study from a single population in southern Italy that maybe showed something. You have 3 more recent studies that were small that didn't, and these were written in 2016, saying there was insufficient evidence to determine whether thyroid hormone does affect pregnancy loss, but maybe consider it, especially in those women with prior miscarriage, because the downside is so low of giving a low dose. Remember, David Cooper talked to you about low doses for older patients. Here, these are euthyroid women who are pregnant, so giving the elderly dose of levothyroxine to a euthyroid woman who's pregnant with positive antibodies. And then we had this study that was just published 4 months ago in the New England Journal. So this is the tablet study from the UK. that looked at almost 20,000 women in 49 hospitals across the UK and included women who were antibody positive who either were undergoing IVF or who had a prior miscarriage. And what they did was they started thyroid hormone preconception. They gave 0.05 milligrams per day, so 50 micrograms daily. Oops, sorry, did I do that wrong? Yeah, 50 micrograms of thyroid hormone a day. It's supposed to be 50 micrograms, oh my God, 50, yeah. So I got this a day in 950 euthyroid women, and their TSH was up to 3.63. But it was two categories of women, either a history of miscarriage or those who were undergoing infertility therapy. And most of them were treated for at least 7 months prior to conceiving. So their primary outcome was live birth at over 34 weeks, so in other words, having a healthy baby, and that their hypothesis for power was based upon at least a 10% increase in live birth weight compared to women who did not get levothyroxine. Their secondary outcomes were they wanted to look at miscarriage and pre-delivery and a number of other things. And they also tried later on to stratify their variables to see if there was an effect in older versus younger women. Maybe there was only effect if you had miscarriages versus if you didn't. Maybe there was only an effect if your TSH was in the upper part of normal versus lower part. And remember, some of these women were in the study because they were antibody positive but were just infertile, versus some of them had had prior miscarriages. And they measured thyroid hormone levels early in pregnancy and throughout gestation. And they found absolutely no difference in the live birth rates between women who were treated or not, and all of the secondary analyses were negative. And so this is where we are. So again, I don't have another conclusion slide to put here except to say we now have a much larger study that looked at preconception treatment of levothyroxine and did not find an outcome. Now there's another study that's going on right now in Rotterdam called T4 Life, and there's another study that's going on in China, and both of them should be available in the next 2 years, and they both also look at preconception levothyroxine. But here's the study that we all wanted. So let's now turn to another woman. What if she is not antibody positive? She has negative TPO antibodies, but her TSH is also 3.4, so in the upper limit of normal, and she wants to know if you should do something for her. And this one is perhaps almost a little bit easier to answer, you would think, but I'm going to show you that from the two studies that have tried to look at this with observational studies. So in other words, not looking necessarily at treatment, but at observation, what they found is one in Italy showed an increased miscarriage risk in antibody-negative women with TSH in the upper part of the normal range compared to those in the lower part, and one here from China that showed no increased miscarriage risk. So at least for that woman, it's probably, we don't have any evidence to treat her if she's antibody negative and the TSH is in the upper limit of normal. With that, I wanted to turn then to what about those women who actually have elevated TSHs, subclinical hypothyroidism defined as an elevated TSH and normal thyroid hormone versus overt hypothyroidism. And during pregnancy, subclinical hypothyroidism is about 1 in 50, maybe as low as 1 in 30 women. Overt hypothyroidism is less common. Well, if we're first going to look at associations, there are two recent meta-analyses that have tried to explore what are the adverse outcomes that can occur in a woman who has subclinical hypothyroidism. And so one meta-analysis looked at 14 cohort studies and 13 potential adverse outcomes. The other looked at 18 cohort studies and 15 outcomes. So let me just show you what they found. Because the problem when you look at these meta-analyses is you're trying to make a conclusion from a number of studies that define the disease or the exposure with variable TSH and free T4 cutoffs checked at different times during pregnancy. And sometimes they tried to assess whether antibody positivity was important versus having the same TSH and being antibody negative. But even though there's a lot of variability within the studies, there are some consistent findings. And so what I want to show you is not the actual tables, but the consistency. So not surprisingly, pregnancy loss is about double in both of these meta-analyses. Placental abruption was found as well, about double, but not all studies. And preterm delivery was also found. So similar observations to what we saw in the epidemiology studies looking at euthyroid antibody-positive women, now in subclinical hypothyroidism, despite the fact that there's a lot of variability in the studies included in the meta-analyses, we are observing the same two potential adverse outcomes: pregnancy loss and preterm delivery. But remember, observation isn't causality. So, by the way, that odds ratio was not quite significant. So, does treatment of subclinical hypothyroidism during gestation help? So, again, this is detected during gestation. So we don't have a study like the tablet study where they started levothyroxine before women became pregnant. But we do have a study from the United States that was published now 2 years ago, where women were treated with subclinical hypothyroidism but started during pregnancy. And this study was done through the NIH, where they have a network of hospitals throughout large cities in the United States. It's called the NIH Maternal Fetal Medicine Unit. And what they did was they identified pregnant women during pregnancy with subclinical hypothyroidism, and they were randomized to levothyroxine. They said this is what we call a pragmatic trial. Although the ideal trial might be to do it before these women got pregnant, it mirrors what happens in real-world practice, where most pregnancies throughout the world are actually not planned, and women do become pregnant and do conceive, and they're generally not seen at 6 to 8 weeks gestation, but they're generally seen somewhere at the late first trimester to early second trimester. So they felt that their trial would mirror what would happen in practice. So this was a huge study as well, with multiple hospitals. Almost 100,000 pregnant women with singleton gestations were screened between 8 and 20 weeks of pregnancy. They defined subclinical hypothyroidism appropriately, a TSH over 4 with a normal free T4. They also looked at women who had low free T4s but normal TSH levels. And the average time for randomization was 17 weeks, which probably represents the population that's treated in this network of hospitals. So this NIH network of hospitals tends to be located in urban areas with lower socioeconomic demographics, so that the average time was around 17 weeks for getting therapy. The average prenatal visit was about 2 weeks earlier. And so they were able to randomize about 700 women with subclinical hypothyroidism, about 500 with a low T4, and they looked at outcomes. And their outcomes were cognitive function of the child at 5 years of age. So they did annual development testing, and they did an IQ at 5 years, and the study was powered to detect a difference in IQ. But they also looked at secondary analyses like, did the babies have a lower birth weight? Were there more NICU admissions? Did they have changes in head circumference? Were they small for gestational age? Did the moms have adverse pregnancy outcomes such as pregnancy-induced hypertension, gestational diabetes, preterm delivery, and abruption? 2 things that had been seen. And again, in this study, there was no difference in any outcome either for subclinical hypothyroidism or for the women with hypothyroxanemia in a randomized controlled fashion, whether they were treated with levothyroxine or not and followed through pregnancy. So people have looked at this study and have said, you know, the degree of hypothyroidism based upon this definition was so mild that you might not actually be seeing the beneficial effect on the severe cases, which are much less common and could have been dampened out because most of the cases had mild hypothyroidism. And that's true, because their upper limit of TSH was 3.9, so 4 and above was considered abnormal. So the mean TSH for the treated patients was only 4.5 and 4.3 for the control patients. And anyone who had overt hypothyroidism was excluded because they received treatment. So it may be that if your TSH was 10 and there was a benefit, you wouldn't see it. Some people have argued that their outcome is really not the most sensitive way to assess if there's a beneficial effect of treating maternal hypothyroidism, and others would just say the timing of screening and initiation of therapy is too late, because we know from studies that were done in the laboratory that maternal thyroid hormone is present as early as 5 to 6 weeks gestation in fetal neurologic tissues. And if you're not starting thyroid hormone until around 17 weeks gestation, you've missed a whole window of 8 to 9 weeks. But that's what we have. And so the way we crafted the ATA 2016 guidelines was that the maternal antibody status influenced when you would initiate thyroid hormone in women with subclinical hypothyroidism. So if the TSH were above 2.5 to the upper limit of the reference range, which might be around 4, versus if the TSH were over the reference range but less than 10, versus if the TSH were over 10. So if you're antibody positive, you might consider giving levothyroxine if the TSH was in the upper part of the reference range, and then you would potentially be more strongly recommended to do it if the TSH were above the reference range, let's say above 4. Whereas if you're antibody negative, then you would, as long as the TSH is in the normal reference range, there would be no recommendation to give thyroid hormone. You might consider it between the upper part of the reference range to 10, but you would do it over 10. But remember, these were written before the 2019 tablet study that randomized euthyroid women with positive TP antibodies and normal TSHs and failed to show an effect. I'd like to just quickly end with hypothyroidism, just to remind you, because it is about hypothyroidism, that this is the case where we do have a lot of data that helps us to understand how to treat women with diagnosed hypothyroidism, reminding you of early on when we talked about gestation, that the T4 pool increases by 40 to 50% during pregnancy, and even women who are antibody positive may not be able to have that elevated free T4 in the first trimester. So if you do have a woman with diagnosed hypothyroidism who's on levothyroxine and she's seeing you and she's planning a pregnancy, one of the things that is recommended is start her lower, so at least when she goes up, there's less likelihood that that first TSH may be frankly elevated. So that preconception TSH should be in the lower part of the reference range and up to 2.5. So if your lower reference range is 0.5, from 0.5 to 2.5. There are some studies that have shown that if it's between 0.5 and 1 versus between 1 and 2.5, you're less likely to need a dosage increase early in pregnancy. And my own practice is to try to get the TSH between 0.5 or 0.3 and 1 before someone attempts to conceive. So we try to optimize their LT4. There, you can check the TSH as soon as the pregnancy test is positive, because the median time for dosage increase is 8 weeks and potentially sooner. And then how you increase the dose depends. You adjust it to keep the TSH in the normal range, but whether you give 2 extra tablets a week or whether you do a dosage adjustment based on the TSH can vary. And the amount that you have to adjust may depend upon maternal hypothyroidism. So if a woman has truly received radioactive iodine for Graves, or surgery for thyroid cancer, or surgery for Graves, or a toxic multinodular goiter, she is athyroidic and she will probably require a 40% increase in dose. If she has Hashimoto's and she was diagnosed when her TSH was 12, she may have some functioning thyroid tissue left, and the dosage increase might only be 25 to 30%. TSH should be followed earlier on in the first part of pregnancy when there are more dynamic changes. Mostly after around 20 weeks gestation, there's very little dosage increase that occurs, and so therefore earlier on in the first trimester, and then maybe once in the mid-gestation and third trimester. It's very important, since many of our women may not have taken vitamins before they got pregnant, to remind them that prenatal vitamins generally contain iron, and many of our women get iron supplements because of anemia diagnosed later in pregnancy. Iron can interfere with thyroid hormone absorption, as can soy milk and calcium supplements, so to separate levothyroxine from those. and then after delivery, just to decrease levothyroxine to the pre-pregnancy dose and recheck the TSH 6 weeks postpartum. So very important for family practitioners, GPs, and endocrinologists to have this education with our patients, because remember, most women, although many women do plan conception, many pregnancies are unplanned, to have this conversation with any woman of reproductive age, that even if she's on a stable levothyroxine dose now, that when she gets pregnant, she will likely need a dosage increase. So to summarize, we talked about reference ranges, that it's decreased at the end of the first trimester, but the upper limit is not as low as we once thought. Thyroid autoimmunity, observations of correlation with the adverse outcomes of miscarriage and preterm delivery in euthyroid women. But in the most recent study, even treating with levothyroxine before gestation did not help. It does influence the TSH cutoff for levothyroxine recommendations, so in antibody-positive women to consider levothyroxine with a TSH between 2.5 and 4. My personal practice is that if I see someone and they've had a prior miscarriage and they're antibody positive, I still treat them with a low dose of thyroid hormone because the adverse effect of 25 or 50 micrograms is so low. For maternal hypothyroidism, although we did have a randomized controlled trial there that showed no benefit, remember those study subjects had TSHs on average of only 4.5, and thyroid hormone was actually, the average time for initiation was after the first trimester. So certainly in our practice, if a woman has subclinical hypothyroidism, most endocrinologists, if not all in the United States, would treat. And certainly for overt hypothyroidism, to optimize the dose before pregnancy with early dosage adjustment. Thank you very much, and this is actually the Love sculpture, so very appropriate for a talk on thyroid disease and pregnancy from Robert, Indiana, that's actually at the University of Pennsylvania.